Bismillahirrahmanirrahim. Today my topic of presentation is safe motherhood. Life does not require that we be best, only that we try our best. Learning outlines of today's presentation is introduction, safe motherhood initiative, pillars of safe motherhood, strategies of safe motherhood, recent updates or MCQs. By the end of this presentation, participants will be able to describe the introduction of safe motherhood initiative, pillars of safe motherhood, and strategies of safe motherhood. Maternal death. The annual The annual number of the deaths of related to it is actually the death of the mother related to aggravated by pregnancy or its management, excluding accidental or incidental causes during pregnancy or childbirth or within 42 days of termination of pregnancy, irrespective of duration and site of pregnancy. The worldwide cause of maternal mortality includes the severe bleeding, which is 30%, sepsis 1%, eclampsia 20%, obstructed labor 7%, unsafe abortion 1%, other direct causes 5%, and indirect causes 35%. The most common cause is bleeding, which is the postpartum hemorrhage, and then comes eclampsia, sepsis, obstructed labor, or unsafe abortion. This is further categorized into direct causes and indirect causes. Direct causes, which are related to obstetrical complications during pregnancy, labor, or childbirth. It includes hemorrhage, hypertensive disorders, infections, induced abortions, extrauterine pregnancy, or obstructed labor. Indirect causes include hepatitis, HIV/AIDS, malaria in pregnancy, sickle cell disease, meningitis, heart disease in pregnancy, acute renal failure, pulmonary ketoacidosis, and diabetic pulmonary tuberculosis or diabetic ketoacidosis. History, if you see history, in 1930, the League of Nations Health Section noted concern about maternal mortality. The first international conference on safe motherhood was in 1987 in Nairobi. It led to the formation of Interagency Group for Safe Motherhood to reduce the maternal mortality in developing countries by 50% in one decade. Therefore, Safe Motherhood initiative was taken in order to reduce the maternal mortality, and it means that ensuring all women receive the care they need to be safe and healthy throughout pregnancy and childbirth. Motherhood should be a time of expectation and joy for women, for family, and the community. Safe Motherhood goal is to improve well-being of mothers through a comprehensive approach of providing, preventing, promotive, curative, and rehabilitative healthcare services. Objective is to improve quality and increase access to family planning and maternal health care services, educate couples to ensure they have the best choice chance for wanted and safe pregnancy, to promote improvement of systems for monitoring maternal and newborn health services, to promote the implementation of evidence-based integrated cost-effective reproductive health intervention with a focus on maternal and newborn health within primary healthcare approach, to conduct operational search to generate best practices and evidence for addressing priorities. Reproductive health programs are some goals and aims of safe motherhood. If we see the traditional safe motherhood picture, the safe motherhood is based on the four pillars, which is based on family planning, antenatal care, clean or safe delivery, or essential obstetric care. These are also the strategic interventions or pillars of safe motherhood based on primary healthcare, which is further laid upon by the equity for women or women empowerment. The four main basic pillars which is presented in this conference is family planning, antenatal care, clean or safe delivery, essential obstetric care. These the basic principles are also the package for mother baby package, and the family planning is to ensure that individual and couple have the information and services to plan the timing, number, and spacing of pregnancy, and antenatal care pillars show that to prevent the complication where possible and ensure that the complication of pregnancies are early detected and early treated appropriately. Clean and safe delivery is to ensure that all birth attendants have knowledge, skill, and equipment to perform a clean and safe delivery and provide postpartum care to mother and baby. And the fourth pillar is essential obstetric care. It is to ensure that the essential care is provided for high risk pregnancy and complication is made available to all women who need it. These safe motherhood is actually, if we see in another angle, is based on antenatal care, which is given during pregnancy, neonatal care, postnatal care, and family planning. And all these components is based on essential maternal and newborn care. But when there is complication during pregnancy occurs, then these essential maternal and neonatal care is not covered through the essential maternal and neonatal care. Then there is need for another there is need for another medical services which is known as emergency maternal obstetric and newborn care, which further require the community participation and community communication and emergency transport availability. Then emergency maternal obstetric and newborn care services is further laid upon for equity for women or women empowerment. Now, within the coming years, the pillars of safe motherhood has been converted into six pillars. Now two more pillars has been added, and then it has become six pillars, which include family planning, antenatal care, obstetric care, postnatal care. Two new pillars which added is include post-abortion care and STD, sexually transmitted disease, HIV control, which is further laid on communication for behavior change, which is also based on primary health care and equity or education for women. Therefore, the two new pillars of safe motherhood has been added, which include post-abortion care, sexually transmitted disease or HIV or controlled transmission control. Family planning is actually already is added, which include information and services to the plan, timing, number, and spacing of pregnancies. Antenatal care is for early detection and treatment of complication of pregnancy. Obstetric care is provide appropriate knowledge and equipment to birth attendants and ensure emergency care for high-risk pregnancy. Now, the obstetric and newborn care is actually the care and healthcare initiatives provided to mother and newborn to reduce maternal morbidity and newborn mortality. And its aim is that the birth attendants have adequate knowledge, skill, and equipment to perform a clean and safe delivery. These are further divided into essential obstetric and newborn care, which encompasses all care that is provided during pregnancy, labor, childbirth, and postpartum period to prevent and manage complication. The essential obstetric and newborn care is a term used to describe the elements of obstetric and newborn care needed for management of normal and complicated pregnancy, delivery, or postpartum period. The essential obstetric and newborn care is further differentiated into two levels. Basic emergency obstetric and newborn care, which include following signal function or key interventions to treat or manage key causes of maternal and newborn mortality, which include management of pregnancy complications by assisted vaginal delivery using a cum extractor or forceps, availability or administration of antibiotics, availability or administration of sedative or anticonvulsants for eclampsia, availability or administration of par antiuterotonics, a drug that causes contraction of uterus like oxytocin, ergometrin, misoprostol, or prostaglandin. But ergometrin should never be given to women with elevated blood pressure because it can precipitate an eclamptic seizure or convulsion. Availability or administration of par-antral drugs for postpartum hemorrhage, infection, and preeclampsia or eclampsia. Manual removal of placenta, manual removal of retained product of conception, resuscitation of newborn, availability or administration of par-antral antibiotics to newborn care. These are actually the basic emergency obstetric and newborn care which is provided at the primary healthcare levels and can be provided by skilled birth attendants of any category, which include providing antibiotics, anticonvulsants, um, pain or sedatives, uterotonic drugs, manual removal of placenta, manual removal of retained product of conceptions, resuscitation of newborn. Then comes comprehensive emergency obstetric and newborn care, which is another level. It includes all the basic essential obstetric services which I already told. With the following additional services is required. It includes surgical interventions such as cesarean section or surgery, blood transfusion, anesthesia, umbilical vein insertion, and or catheterization and intubation of the newborn. The comprehensive emergency obstetric and newborn care are basically provided at referral hospitals by trained physician, clinician, or specially trained midwives. Whereas basic emergency obstetric and newborn care can be provided at primary healthcare level by skilled birth attendants or midwives. If we see the essential obstetric and newborn care is further divided into two levels: basic emergency obstetric and newborn care and comprehensive emergency obstetric and newborn care. Postnatal care is also provided in safe motherhood, which include for both mother and baby, which include lactation assistant and counseling, family planning services, immunization of child, management of complications of delivery. There is also post-abortion care, which is another pillar added, which include management and complications of management and complication which arise during abortion, and also there is family planning consultation. Sexually transmitted disease or HIV control include voluntary counseling and testing and prevention of mother-to-child transmission, PMTCT. If we see that safe motherhood resource limiting setting, that the emergency maternal and obstetric newborn care services is totally based on referral services, and it requires the community programs or community participation, and also the emergency transport facilities, availability of emergency transport facilities. These are the essential medical obstetric care, include the eight components. Six is the basic, and two are the comprehensive. I already mentioned it include antibiotics, oxytocin drugs, anticonvulsant, blood transfusion, mineral removal, placenta, retained product of conception, assisted vaginal delivery, or C-section. Now, approaches to attain safe motherhood. It include at the antenatal care level, we can conduct the home visiting, we can establish the prenatal clinics, we can also establish the observation beds. At intranatal level, there should be domiciliary midwifery services. Medical advice should be given by medical officers. There should be maternity homes. Safety kit is provided to traditional birth attendants. There should be diagnostic facilities, ambulance facilities. In postnatal care, there should be home visiting for postnatal checkup. There should be welfare clinics for supply of milk, health education regarding immunization or family planning counseling. There should be growth monitoring of child, or there should also be hospital beds for dealing with any complication during postpartum period. Therefore, the safe motherhood strategies include a range of services which include tetanus immunization, access to maternity care, availability of trained birth attendants, providing a clean environment for birth, referral centers, essential maternal obstetric care, emergency obstetric care, emergency maternal obstetric care, health education, family planning, SOPs and training, intersectoral coordination, or community participation. Other indicators of safe motherhood include infant mortality rate, total fertility rate, contraceptive prevalence rate, antenatal coverage rate, percentage of deliveries assisted by skilled birth attendants, percentage of women who took iron during pregnancy, or percentage of institutional delivery, or percentage of cesarean section or other obstetric case fatality rate. We can all therefore we can reduce the maternal mortality rate by strengthening of the health system to provide emergency obstetric care services, community-based skilled birth attendant program, emergency obstetric care as important backup service in all the facilities. It should be important backup facilities in all facilities of MCH. Demand side financing maternal health voucher schemes. Now come the three delays model, which is also very important to in discussion with maternal mortality. This model, according to this model, there is three delays actually prior to maternal deaths. First delay in seeking care, second delay in reaching care, and third delay in receiving care. Delay in decision to seek care is actually related to various factors which include lack of understanding of complications, acceptance of maternal death, low status of women, social cultural barriers. Delay in reaching care include transport problems. There is also transport cost. Or delay in receiving care is include the lack of supplies of personal healthcare in hospitals, poorly trained hospital with bad attitude, or poor motivation of health care providers, and there is lack of finances. Therefore, if we see the three delays model, then the first level of decision actually there is lack of decision or lack in seeking recognition of danger signs due to poor knowledge of women and perceived low quality of care, traditional beliefs or cultural norms, concerns about accessibility and cost of care, and bad experience of women during the past previous pregnancies. To deal with first level of delay, we can possible intervention. We can take include health communication to raise knowledge of and awareness of danger signs and to seek care of mother, detection of newborn danger signs through early postnatal home visits by community health workers, facilitated referrals by community health workers, improved communication and engages the source of care, financial incentive for seeking care, and increased decision making power of mother. The second delay, which is actually in reaching the facility, or appropriate source of care is actually the distance to source of care, lack of transport. There is also transport cost, time and opportunity cost, security concerns. For these possible interventions, there should be bringing appropriate care closer to community, facilitated referral by community health workers, mobilize or provide transport, funds to recover or minimize cost. Third delay is actually obtaining an adequate appropriate treatment. These are actually due to lack of equipment and supplies, lack of trained staff, poor attitude of staff. These can be tackled with provision of equipment and supplies, improving staff capacity and attitude through training and supervision, improving staff availability, ensuring cases are referred back to community health workers with follow-up instructions and referral monitoring. Therefore, the antenatal coverage is we see that it's actually the proportion of pregnant women attended at least once during their current pregnancy by healthcare professionals such as health extension practitioners for reasons related to pregnancy. Calculating the health antenatal care first visit coverage provides information on percentage of women who use antenatal care services. This antenatal care coverage rate or antenatal coverage rate is calculated as the total number of pregnant women attended at least once during their pregnancy by health professionals for reason related to pregnancy divided by the total number of expected pregnancies during a given time period, usually in 1 year, in the catchment area, and it is usually expressed in percentage by multiplied by 100. Therefore, antenatal care coverage rate include number of first antenatal visits um, of women divided by total number of expected pregnancies multiplied by 100. Therefore, we have mentioned the three delays of model. First delay is to seek care, second delay is to reach help, or third delay is to receive acceptable help. There may be also fourth delay which should be we consider, which include would we take responsibility for maternal mortality as government has taken no responsibility for maternal mortality. Therefore, fourth delay may be to take responsibility for maternal mortality. Now come the recent updates. In reproductive maternal and child health care program, it is a new strategic approach is mentioned, which include premise and premise approach. The two approaches include that the maternal and child health cannot be improved in isolation. Adolescent health and family planning have an important bearing on the outcome. The two approaches now are mentioned in this program is life cycle approach for improving maternal and neonatal child health and concept of continuum of care and a special focus on adolescent linking community and facility based care. These across life stages, which include the reproductive, maternal, newborn, child health, and adolescent initiative. The across life stage approach include the newborn period, then childhood period, then adolescent period, and then pregnancy, which is reproductive years. If we see across levels of care, various appropriate reference follow-up levels include health facilities at various levels, for example, primary healthcare level, district healthcare level. Out there is outreach services and also family health and community care. The continuum of care across life cycle level of care, which is actually provided, include the adolescent or pre-pregnancy level. At this level, family or community care, which is provided, include sexual reproductive health, community-based promotion, and delivery of contraceptive, menstrual hygiene. On outreach or reproductive healthcare, there should be family planning, STI prevention, periconception, folic acid supplementation, and at clinical site reproductive care include comprehensive abortion care, sexually transmitted or reproductive tract case management, IUCD insertion or sterilization, adolescent friendly health services. In pregnancy and birth, various family and community level are counseling and preparation for breastfeeding, birth preparedness, demand generation, and in outreach services, antenatal care packages given, and also in clinical level, pregnancy and childbirth care includes still obstetric care, immediate newborn care, resuscitation, and also HIV/AIDS prevention is also. tackled. And if we see the newborn and postnatal care, the postnatal care is provided at outreach services, early detection, management of illness, immunization, and at clinical, the newborn and child care is provided, include care of sick-born care, IMNCI, immunization, and in childhood, various child health care, assessment of care of newborn, immunization of micronutrient supplementation, child health screening, early childhood development, danger sign recognition, and care seeking. There is also the White Ribbon Alliance for Safe Motherhood in a grassroots level movement that builds alliance strength, capacity, influences policies, and inspire action to save the lives of women and newborn around the world. The history and mission of these is founded, it is actually in 2006, United Public Health Expert and Safe Motherhood activist, researcher and media representative that are committed to save motherhood in Pakistan, where all women and girls realize their right to quality health and well-being. And there is also SDG 3, Sustainable Development Goal, which deal with good health and well-being. And these there is also indicators to reduce the global maternal mortality ratio to less than 70 per 1 lakh live births. And SDG 3 2 also shows that there is unpreventable deaths of newborn and children under 5 years of age. And SDG 3.7 ensures universal access to sexual and reproductive healthcare services. Safe Motherhood in Pakistan, Past Failures and Future Challenges shows that the death of Pakistani women during pregnancy, delivery, immediately after delivery, and or her newborn is calamity or incalculable dimensions not only for her family or community but from perspective of health policy makers and planners. As for 21st century, the real challenge facing our nation is safe motherhood lies in implementing maternal health policies. The essential core of Safe Motherhood initiative should be an intersectoral, multi-level programmatic framework that links the common women and men in the community. Obstetricians, midwives, nurses, and educators is supported by strong critical commitment at the national, provincial, or district level. There is also Safe Motherhood and COVID-19. The novel COVID-19 virus is caused by infection in severe acute respiratory illness has become a global public health emergency. The adherence to infection prevention and control particularly important to prevent the contact transmission between COVID-19 mother and newborn. The mother should wash hands with soap and water with hand sanitizer at least 60% alcohol for at least 20 seconds. Try to avoid cupping and sneezing on the baby while feeding. Wear a mask while feeding. Follow recommendation for cleaning the pump or bottle after each use, or consider asking someone who is healthy to feed the express breast milk to the baby. There is also Mother Baby Package implementing safe motherhood in countries practical guide developed by WHO. In this Mother Baby Package, which describes each intervention needed to achieve safe motherhood in short term. It represents the synthesis of activities at different levels of healthcare system and defines a basic set of health system interventions and activities. The package describes simple intervention during pregnancy, during delivery, after delivery for mother and newborn. And it also outlines to prevent and manage the major obstetric complication in the community and at the healthcare center and at the hospital. Implementation of Mother Baby Package. The district health system is the basic unit for planning and implementing the intervention outlined for Mother Baby Package developed by WHO. The district provides a mechanism for linking families and communities with other health centers and hospitals in functional, cost-effective manner. An article is published, Death Paying Until Death, revisiting three delays model to contextualize the socio-cultural factors associated with maternal deaths in regions with high prevalence of eclampsia in India. This article showed that a disproportionately high proportion of maternal death in the world occur in low and middle income countries, of which 90% is contributed by sub-Saharan Africa and South Asia. This study used the three delays model to assess the socio-cultural barriers associated with maternal mortality in West Bengal, India. It was actually a retrospective mixed method study which used facility-based and community-based approaches. And the results of this study show that the delay in seeking care, which is a type 1 delay, was the most significant contributor to maternal deaths, 48%, followed by the second major impacting contributor to maternal death was delay in reaching first level care facility, while delay in receiving adequate care at the health type is 18%. The study concluded that The type 1 and type 2 delays were the major contributors of maternal deaths in the study region. Therefore, to prevent the maternal deaths effectively, action and will be required to in areas like strengthening the functionality of referral networks, expanding coverage of healthcare, and raising awareness regarding the maternal complication. There is also another article published which show the regional effects of maternal mortality determinants in Africa and Middle East. This research shows that the United Nations Women data, the maternal mortality rates in war-affected countries critical and more than 800 million people lives in war-affected countries. External and internal conflictors such as foreign pressure, war and cross-border civil disorders, terrorism and civil war, the characteristics of Middle East and African countries. The data were collected from 46 countries during 2011 to 2016 to explore the regional contribution of political risk factors to maternal mortality. The result of this article shows that the GDP per capita, energy intensity, urbanization strongly impacted maternal mortality. And it was also observed that natural resource rents and economic growth significantly influenced the reduction of maternal by expanding healthcare services. The finding revealed that critical risk arising from terrorism, foreign pressure, war in the adjacent countries would elevate the rate of maternal mortality in regional countries. This improved the if spillover impacts of regional countries, conflicts of maternal mortality elevation at the regional scale. Now time for MCQs. MCQs number 1. Ending preventable maternal death must remain at the top of global agenda. Maternal health services that make pillar of safe motherhood include alpha adequate medical care by skilled health personnel before and during after child health, beta prevention of mental health issues, C prevention of gastrointestinal infection, delta prevention of safe drinking water, E prevention of adequate nutrition. What will be the correct option? Alpha will be the correct option. I already mentioned that the skilled birth personnel or providing prenatal, intranatal, and postnatal care is the pillar of safe motherhood. Therefore, alpha will be the correct option. MCQs 2. According to the World Health Organization, 70% of nations in world have a high maternal mortality rate. Which of the following has positive impact on maternal health? Alpha early marriage, beta female genital tract infection, C inadequate nutrition, delta anemia, E adequate health service coverage. What will be the option? Positive impact on maternal health is only improved by providing the adequate health service coverage. Therefore, E will be the correct option, whereas all other factors has negative impact on maternal health. MCQ3. The majority of maternal deaths are avoidable with prompt intervention with qualified health practitioner working in a supportive atmosphere. Which of the following is indirect cause of maternal death? Alpha hemorrhage, beta unsafe abortion, C anemia, delta obstructed labor, E heart disease in pregnancy. As I already mentioned that indirect cause of maternal death is the heart disease in pregnancy, other disease, malaria. Therefore, E will be the correct option, whereas all other causes are direct cause of maternal death. MCQ score. Of the 40 verbal autopsies, 35 women delayed seeking medical attention in ABC hospital. Estimating the seriousness of complication, cultural beliefs, and norms experiencing with the healthcare system are all blamed for delay. Some people have mentioned a barrier to getting medical care as not having enough money. In this scenario, the critical level of delay is alpha, first level delay, beta, second level delay, C, third level delay, delta, fourth level delay, or fifth level delay. What will be the correct option? The correct option is alpha first level delay, as I already mentioned that cultural beliefs and norms are come under the first level delay. MCQs 5. The proportion of pregnant women attended at least once during the current pregnancy by health professionals such as healthcare practitioners for reason related to pregnancy is known as alpha attended birth, beta antenatal care coverage, C maternal care, Delta health service coverage, E per spacing. Beta will be the correct option, antenatal care coverage. MCQ 6. 3 delay model identifies 3 critical phases that would directly affect the mother's and baby survival. The third level of delay is alpha lack of transport, beta lack of money, C lack of trained staff, delta traditional belief, E transport cost. What will be the correct option? The third level of delay I actually mentioned C will be the correct option, lack of trained staff. MCQ 7. Basic obstetric and newborn care is crucial to lowering mother and neonatal mortality. The following are not included in emergency obstetric care. Alpha, manual removal of placenta, beta hysterectomy, C blood transfusion, delta cesarean section, E administering antibiotics or uterotonic drugs. What will be the correct option? Beta will be the correct option as already mentioned that hysterectomy is not come under the emergency obstetric care. MCQs 8. In the ABC community, if the total number of first antenatal visits equal 100 and the total number of pregnancies equal to 100, the community antenatal coverage will be alpha 30%, beta 40%, C 50%, delta 60%, E 70%. What will be the correct option? Here's simple calculation. You can divide the total number of antenatal visits by the total number of pregnancy multiply 100. 50% is antenatal coverage, therefore C will be the correct option. MCQs number 9. Three-delay model is being used in the APC research project to examine its applicability and potential to assist a solution-based strategy for gaining access to intrapartum care in the XYZ community. The study resulted in the conclusion that the shortage of equipment and supplies in the healthcare facility is to account for delay. In this scenario, the critical level of delay is alpha, first level delay, beta second level delay, C third level delay, delta fourth level delay, or fifth level delay. What will be the correct option? Anyone from the class? Dr. Amna, you can tell this answer, Dr. Satya. MCQ number 9 is the actually the I already mentioned that the third level delay C will be the correct option. That lack of shortage of supplies and equipment in healthcare facilities is actually the third delay. Therefore, C will be the correct option. It is very easy MCQs. I think you don't listen the presentation carefully. MCQ number 10. If properly developed community-based safe motherhood interventions can effectively address all barriers at the family and community level. No safe motherhood program can successful until dash delays are addressed. Alpha cultural factors, beta socioeconomic factors, C transport cost, delta poor attitude of staff, E by providing adequate health education awareness as well as skilled personnel improve transportation services. What will be the correct option? Anyone from the class? I already mentioned that in order to reduce the maternal mortality and providing the community-based safe motherhood, you should address all the three delays, which is actually the barrier to communication, providing a safe motherhood, Therefore, E will be the correct option by providing adequate health education, awareness, as well as skilled personnel and improved transportation services. This is the key of my MCQs, and thank you.